Hello, welcome to the World Thrombosis Day 2020 webinar, co-hosted today by the International Society of Thrombosis and Haemostasis, ISTH, and by the Division of Blood Disorders at the Centre for Disease Control and Prevention, also known as the CDC. Today's webinar explores the very timely and important topic of COVID-19, coagulopathy and thrombosis. So I'm Professor Beverly Hunt. I'm really delighted you're here today. I'm going to be your moderator. I'm the chair of the World Thrombosis Day Steering Committee, and I'm also a practicing physician and professor of thrombosis and hemostasis at King's College in London, and also an active consultant at Guy's and St Thomas's Trust. Well, today is finally World Thrombosis Day. We've been waiting for it for such a long time. We're really excited to have you with us for this webinar and to celebrate World Thrombosis Day together. World Thrombosis Day is a global movement recognized each year on the birthday of Virchow on October the 13th, and it focuses attention on the often overlooked subject of thrombosis, particularly venous thromboembolism, or VTE. So this year, the COVID-19 pandemic has undoubtedly brought forth enormous challenges in global healthcare, and it's brought to the forefront the problem of thrombosis. And we know that with COVID, especially with COVID pneumonia, you have an increased risk of blood clotting. As such, for today's webinar, we've brought together leading thrombosis experts from around the world to discuss the association between the coagulopathy, thrombosis, and COVID-19. Our presenters are all members of the World Thrombosis Day Steering Committee. We have Dr. Lana Castellucci, Dr. Alex Spiropoulos, and Dr. Claire McIntosh, who I'll introduce to you before each of their presentations. But before we get started, I would like to learn more about who we have on today's webinar. A poll question will appear momentarily on the screen, and we invite you to answer it. Our first question is, what region of the world are you from? I'll give everyone a moment to answer this. I've got the results finally. So looking through, we've got 41% from North America, 30% from Western Europe, 13% from Asia, 7% from South America, and 3% from Africa, 6% from Eastern Europe and Russia, and we're still waiting for someone from Australasia to join us, but then it is midnight there. Okay, before we start, there's a few technical matters that we need to go through. We want the webinar to be as interactive, and as such, we encourage you to submit your questions to our presenters using the question tab on the left-hand side of your screen. Please ask any questions at any time. We're going to be monitoring the questions, and we will try to address as many as possible at the question and answer session at the conclusion of the webinar. I would also like to point out there's a great feature for those who want to take notes. You can put it into the Notes tab on the right-hand side of the screen, and you'll see a white text box where you can add in whatever you want, and these notes will be emailed to you at the end of the presentation. And then if you're interested in a PDF of the PowerPoint slides, you can click on the Resources tab on the left-hand side of the player. Simply click on any of the file names to initiate the download. A recording of the webinar will also be available there. So we're going to have a few more polls through the presentation for you to share your input. If you do have technical problems, you can click on the Request Support button in the lower left of the player, and we have a technical expert ready to help you. Okay, so enough of the techie stuff. Let's get going. And I'm going to just give you a background of COVID to set us up for today. So here we go. Just to remind you that the SARS-2 virus, which causes COVID-19, binds to nasal and pulmonary epithelium and enters the body that way. And within the body, there are a large number of cells that have ACE2 receptors on them. They include macrophages, lymphocytes, myocardium, endothelium, and adipocytes. And then looking at the ACE2 receptor, I think the data is slowly coming through, showing the variability in distribution of the ACE2 receptor between different ethnic groups. And this particular paper looked at the amount of expression on the nasal epithelium, and you can see it's related to age. So maybe one of the reasons that children have less severe infections is they have a lower dose of virus. So thankfully, with COVID-19, the majority of patients will have an asymptomatic infection or minor symptoms. We know that some get fever and cough, others might get headache and myalgia, and there's a subset who lose sense of taste and smell, which is a fairly good prognostic factor for not getting COVID pneumonia. But then we have the problem that somewhere about 5% of the population will develop COVID pneumonia. And this is a major issue. We get a massive inflammatory response within the lungs, and this leads to quite severe hypoxia. And the reason, certainly in the UK, and I suspect in your country, the reason we are admitting patients to hospital is because they are hypoxic. And we divide into moderate COVID, where they just require oxygenation, or severe COVID, where they need mechanical ventilation to deliver adequate oxygenation. So part of this amazing inflammatory response is that there are a number of cytokines going to the liver and switching on production of a vast number of coagulation factors and leading to this profound prothrombotic state. What's interesting, I think, is that those who have risk factors for severe COVID, so let's remember what they are: being male, being older, being obese, having diabetes, or having cardiovascular risk factors, are all slightly prothrombotic states. And therefore, it's an interesting association. The other thing to say is we need to remind ourselves of some basic principles of coagulation. So coagulation did develop as an effector system of the immune response. And primitive organisms developed the coagulation system to produce fibrin to wall off invading organisms such as bacteria. And the sort of other effect of that is if you have profound inflammation, as you do maybe in Behçet's disease and the vasculitides. I used to run these clinics for many years. These patients will have microvascular thrombosis at the site of high inflammation. And we treat those patients not with anticoagulation. I mean, they end up on anticoagulation, but the only way of stopping that microvascular thrombosis is to give them immunomodulatory treatment, such as giving them steroids. And lastly, the sick patients on the wards are hypoxic, and hypoxia is an incredible driver of a prothrombotic state through the hypoxia-inducible transcription factors binding to the promoter areas of genes like tissue factor and PI1. Lastly, just thinking about obesity, the adipocyte is not the inert little cell you thought it was. It has its own repertoire of cytokines, and in those patients who are overweight, the cytokine profile is very pro-inflammatory. And when we look around our critical care units in the UK, we know that 75% of the patients who've got severe COVID are overweight. So we've got adipocytes expressing the ACE2 receptor, so they're a reservoir for COVID-19, and it may also be that COVID-19 is switching on their pro-inflammatory phenotype as well. We need more research there. So when are people at risk of venous thromboembolism with COVID? Well, they acquire the infection and they may not be very well, but in most countries they are staying at home. And so maybe if they get a little bit immobile, they might be at increased risk of VTE. But if they unfortunately get COVID pneumonia, then they're admitted to hospital and we have the risk of hospital-associated VTE for up to 90 days post-discharge, which is the definition of hospital-associated VTE. And of course, as we go along, we're learning more about COVID. We've got long-term sequelae. So we've got a syndrome known as long COVID, really, which sounds like post-viral syndrome. Patients have fatigue, shortness of breath, feel terrible. And we also have some unique symptoms and signs that can occur late, such as COVID fingers and toes, but they can also occur early. I don't know what's going on in your country, but in my country, with the first wave, there were a number of patients who decided they didn't want to go into hospital. And I'm really thinking of healthcare professionals, and they thought they'd struggle at home, being very hypoxic and just rest. And I'm not sure, but some of those have developed VTE. I'm not clear on the size of their risk. So that's really it from me, preparing the way for the speakers. And I would like to introduce you next, Dr. Lana Castellucci, who will be discussing hemostatic changes in COVID-19. Dr. Castellucci is an assistant professor in the Faculty of Medicine at the University of Ottawa and an associate scientist at the Ottawa Hospital Research Institute in Canada. Thank you so much for being here today, Lana. Over to you.
Good morning, everyone. Thank you very much for that kind introduction, Dr. Hunt. So I'd like to talk about coagulation changes in COVID-19, and the outline is shown here. We'll briefly discuss the etiology and epidemiology of what we know today about COVID-19 infection, briefly discuss the risk factors associated with COVID-19 infection, as well as with acquiring adverse outcomes. Finally, we'll talk about mechanism of coagulopathy, the clinical manifestations, and some biomarkers that we're using to follow coagulopathy and associated outcomes such as mortality. COVID-19, as we've heard, is due to the severe acute respiratory syndrome coronavirus 2, or SARS coronavirus 2, and this is an RNA virus belonging to the beta coronavirus genus, and this genus also includes SARS coronavirus 1, which was responsible for the epidemic in 2002 and 2003. Most recent information regarding epidemiology of COVID-19 infection can be found on the World Health Organization website, as well as the Johns Hopkins University World Tracker. With respect to severity of disease, we know that it is variable, and approximately 10 to 15% of symptomatic patients will require hospital admission, with up to 20% of those patients needing intensive care unit or ICU care. I took a picture of this slide this morning at about 7:30, and this is the up-to-date information from the Johns Hopkins World Tracker of COVID-19 infection. And as you can see, nearly 38 million people worldwide have been infected with COVID-19, with over 1 million deaths as a result of it. Last week, the World Health Organization estimated that 10% of the world population has been infected with SARS coronavirus 2. And this, of course, depends on where you live and the type of setting one lives in, whether it's an urban setting or a rural setting. but we know that this is certainly ongoing and we need to be mindful of what we can do to mitigate complications from it. As Professor Hunt mentioned, there are risk factors both for acquiring COVID-19 infection as well as those associated with adverse outcomes once one has the infection. And these include advanced age, male sex, obesity, with risk increasing as one's BMI increases, active smoking, diabetes, and cardiovascular disease. I'll briefly touch on the coagulopathy as it was already discussed. We know that the SARS coronavirus binds to the ACE2 receptor using the spike glycoprotein on the viral envelope. And as mentioned, this ACE2 receptor is quite distributed throughout the body, involving the lung, heart, brain, kidney, as well as the endothelium. And when the virus does cause infection, it results in a pro-inflammatory response with endothelial injury resulting in an inflammatory response and an immune activation from the host. That endothelitis contributes to not only vascular injury, but hypercoagulability and increased rates of thrombosis. The clinical impact of COVID-19 coagulopathy, as we heard, is involving venous thromboembolism, or VTE, comprised of deep vein thrombosis and pulmonary embolism. And what I want to touch on here is that pulmonary embolism, what's unclear is whether this is true pulmonary embolism such that one has concurrent deep vein thrombosis, or if it's more in keeping with thrombosis in situ as a result of the pro-inflammatory effect from lung infection. And what we know, and I'll mention on the next slide, is that rates of VTE diagnosis are variable depending on severity of illness. There's also reported arterial thrombotic events, and these include stroke, cardiac injury such as myocardial infarction or heart attacks, and acute kidney injury. And rates of arterial thrombotic events are not nearly as high as those reported for VTE. Arterial events are approximately 4 to 5%. Early on, when we were learning about COVID-19 coagulopathy, we didn't hear much about bleeding as a complication of the coagulopathy. But now we're starting to see some reports of bleeding events, and it'll be important to balance that when we talk about how do we mitigate risk of VTE. When we're looking at VTE and we talk about pulmonary embolism or pulmonary thrombosis in situ and deep vein thrombosis, we look at hospitalized patients who are admitted with COVID-19 infection. And depending on the severity of their illness, those not requiring intensive care unit admissions or ward patients, approximately 5 to 10% of them will develop pulmonary embolism or deep vein thrombosis. For those that are severely ill and do require intensive care unit admission, up to 30% will develop pulmonary embolism or deep vein thrombosis. And what is also important to know about the coagulopathy of COVID-19 is that VTE can occur despite using prevention doses of anticoagulation. Most commonly, we see that low molecular weight heparins are used when patients are hospitalized, and there are ongoing trials evaluating dosing strategies to mitigate risk of VTE, and those will be discussed by my colleagues later in the presentation. Next, I'll move to biomarkers that we associate with COVID-19 coagulopathy. And this is a nice summary table reporting biomarkers that were found to be associated with COVID-19 infection. And early on, we learned that approximately 20 to 30% of patients develop a mild thrombocytopenia. And importantly, as with other viral infections, many patients develop lymphocytopenia, with approximately 80% having absolute lymphocyte counts of less than 1.5. With respect to prothrombin time, we know that it can be mildly prolonged, and fibrinogen early in the disease is found to be quite elevated, but as the disease progresses, it can be reduced, and it's expected to be reduced. I've skipped over D-dimer because I'm going to focus on this for the remainder of my presentation. The D-dimer is a very important marker that we've found to be associated with increased rates of mortality. And in particular, as the D-dimer level increases, the rates of mortality also increase. So D-dimer is a degradation product of fibrinolysis, and it's elevated not only in acute VTE, but also other conditions, including COVID-19 infection, as well as non-COVID-19 related respiratory illness. What we don't know about the elevated D-dimer is whether it's resultant from the COVID-19 hypercoagulability, or is it a consequence of diffuse inflammation caused by the viral infection. Early reports from Wuhan, China, looked at a retrospective cohort of 1,100 patients. And what we saw with those 1,100 patients is that those admitted to hospital and had abnormal D-dimers above 500, approximately 45% of them had elevated D-dimers above 500. When we looked at the severity of their pneumonia, we found that not only was it indicative of severe pneumonia, but the higher the D-dimer threshold, the more severe the pneumonia. So for patients classified as having severe pneumonia, which was approximately 60%, they had a D-dimer elevated above 500, compared to those with non-severe pneumonia, where it was elevated in approximately 40%. In this cohort of 1,100 patients, they also looked at a composite outcome of those requiring mechanical ventilation, admission to ICU, or death. And 70% of their cohort had a complicated course meeting this definition, and they were found to have D-dimer levels above 500. More information from Wuhan, China is shown here on this slide. Two different studies reported on the association of D-dimer elevation and increased mortality rates. And in the first table, this is a combination of data from two hospitals in Wuhan, and they looked at various D-dimer thresholds. And what they found was that as the D-dimer increased, the rate of survival decreased. And so with patients who had D-dimer thresholds above 1,000, the survival rate decreased substantially. When we looked at another hospital and their data from China, they also reported mortality rates of approximately 40%. In this particular cohort of about 150 patients, what you saw was that patients who didn't survive had a median D-dimer level of about 4,600 compared to survivors whose level was around 600. And so again, what we're seeing is that the higher the D-dimer, the greater the association with mortality. Another study from China showed similar findings. What this shows is over a time course of approximately 14 days, and they looked at information comparing the D-dimer levels at the time of admission compared to later in the admission. And at the time of admission, what you can see here is that the higher the D-dimer level, the greater the mortality. So non-survivors are shown in green and survivors are shown in blue. So this was a significant difference, that if one had a high D-dimer level above the 500 threshold, their risk of mortality was highest compared to those with a relatively normal D-dimer. And as the admission went on at day 10 and day 14, again, as the D-dimer level approached significantly higher numbers of 21,000 compared to those who had relatively normal D-dimers, the rate of mortality was significantly higher. An interesting finding is that we don't know if elevated D-dimers are normal in ICU patients. And this is a retrospective study that looked at patients with COVID-19 infection, about 450 of them, and looked at 100 patients without COVID-19 infection and compared them with respect to outcomes such as 28-day mortality. And they also looked at D-dimer levels. And what we saw is that in patients with COVID-19 infection, they had a mortality rate that was approximately twice as high as those with non-COVID-19 respiratory infection. When we looked at the D-dimer level, however, it was not significantly different. And so again, we don't know in intensive care unit patients what this means in terms of differences between COVID-19 infection compared to non-COVID-19 respiratory illness. So in summary, what I'd like to focus on for COVID-19 coagulopathy is that we know this infection is a hypercoagulable state and it is associated with increased risk of venous thromboembolism. The elevated D-dimer is commonly seen, but it's unclear if it reflects true hypercoagulability from the viral infection leading to thrombosis, or if it's a result of the diffuse inflammatory response. What we also know, however, is that it is associated with an increased risk of mortality. And next, I'm going to turn it over to my colleagues to discuss what the role of VTE prophylaxis is in patients with COVID-19 infection. Thank you.
Fantastic. Thank you, Lana, for your presentation. And we will have a discussion about it at the end. We now need to move on. I'd like to introduce our next speaker, Dr. Alex Spyropoulos, for an important update on thromboprophylaxis and COVID-19. Dr. Spyropoulos is a professor of medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell in New York City, USA, and he's also system director of the Anticoagulation and Clinical Thrombosis Service for Northwell Health. Over to you now, Alex.
Thank you very much, Beverly, for that kind introduction. So these are my disclosures, and I will be discussing thromboprophylactic strategies in COVID-19 patients with a focus on the hospitalized COVID patient. And by way of introduction, I think none of us need to be reminded of the ravages and implications of COVID-19 disease caused by the SARS-CoV-2 virus, as was stated nicely by the previous speaker. In the United States alone, over 7 million cases and now more than 215,000 deaths and counting. We also now can appreciate that thrombotic complications have been associated with up to 60% of deaths, especially in patients with underlying cardiovascular disease. And autopsy series reveal a high incidence of unsuspected venous thromboembolic disease, or VTE, in these patients. We also know, as a subset of hospitalized medical patients in the pre-COVID era, these patient populations, including those with viral pneumonia and sepsis, had been at moderate to high VTE risk, and we can expect anywhere from a 50 to 60% reduction of that risk using in-hospital thromboprophylaxis. Also, more data now recognizes that there's a subset, about 25% of medically ill patients at high VTE risk that would likely benefit from a strategy of post-hospital discharge extended thromboprophylaxis using a direct oral anticoagulant such as rivaroxaban or petrixaban. And lastly, previous experience with viral pneumonias, especially in the setting of acute respiratory distress syndrome, have shown a multifold increased risk for VTE, with at least some data suggesting a significant reduction of that risk with the use of empiric therapeutic dose anticoagulant therapy. More recently, we have now developed sophisticated tools such as the validated VT risk assessment improved tool and elevated D-dimer, which Lana beautifully described as being very important in the COVID era, that predicted a higher VTE risk group of patients that would benefit from extended thromboprophylaxis. Now, I'm not going to go over details of the coagulopathy and cytokine storm in SARS-CoV-2 pneumonia and this phenomenon of thromboinflammation that was nicely discussed by the two previous speakers. Suffice to say that entry of the SARS-CoV-2 virus produces, again, a cytokine storm, as is evidenced by complement activation, endothelial cell dysfunction, contact pathway activation, and ultimately thrombin generation and a hypercoagulable state. And with respect to risk factors for thrombosis in COVID-19, we have what have been classically described as risk factors in the acutely ill medical patients, such as advanced age and mobility, in the presence of concurrent cancer or concurrent cardiopulmonary disease, but also more specific virus-associated risk factors, especially due to the immense inflammatory response and endothelial dysfunction of the superinfected individual. We have evidence of a decrease in tissue factor pathway inhibitor, lymphopenia, and the marked elevation of inflammatory cytokines, especially IL-6, elevated D-dimers, as was described previously, and elevated cardiac biomarkers, all leading to both microvessel disease, including pulmonary microthrombi and intravascular coagulopathy, as well as more classic macrovessel disease, including venous thromboembolism, myocardial infarction, stroke. Also, as was suggested by the previous speaker, there appears to be only a minority of patients, about 10 to 15%, which present with classic disseminated intravascular coagulopathy, and also very few percentage of patients have been described as having a bleeding diathesis. So, to summarize antithrombotic strategies in this population, we have to think of three potential conceptual targets: targeting the inflammation system with anti-inflammatory agents, including general agents such as corticosteroids, and recently they have shown benefit, especially in the critically ill COVID-19 population, but also more targeted approaches such as IL-6 inhibitors and the potential for complement pathway inhibitors as well. Of course, it makes sense to think about targeting procoagulant factors, including direct factor 10A inhibitors, direct thrombin inhibitors, of course, antiplatelet agents, which may target and decrease platelet-derived thrombin generation, as well as more novel mechanisms, including the potential for contact pathway activator inhibitors, such as factor 11A inhibitors. And lastly, a third mechanism would be to enhance the body's natural anticoagulant pathways, including antithrombin-dependent mechanisms such as our friend on fractionated heparin, low-liquid heparin, and fondaparinux, in addition to other less described but novel mechanisms, activated protein C and thrombomodulin-based mechanisms as well. So we have to think of this as a multimodal process. As described by the previous speaker, we now have a much better sense of what are some of the key predictors of thrombosis in hospitalized COVID-19 patients. And these include patients with elevated sepsis-induced coagulopathy, as was shown previously, very elevated D-dimers greater than 4 times or even 6 times the upper limit of normal, portend a poor prognosis, and also an increased risk of thrombotic complications, as well as other more classic risk factors that have been previously described: advanced age, obesity, underlying cardiovascular morbidity, and importantly, stay in the ICU with mechanical ventilation. Now, very early on, many clinical researchers did, number one, not only note the thrombotic complications inherent in SARS-CoV-2 infected individuals, especially those who were hospitalized, but also the unusual nature of these thrombotic complications, and specifically venous thromboembolic disease, which encompasses the majority of thrombotic complications in these patients. And these indeed represented a perfect storm of the coagulation system, immune system, and inflammatory system, as was previously described. And the first thing that was noted was the high prevalence of thrombotic complications in hospitalized and especially critically ill COVID-19 patients. These included DVT rates as high as 46% to as much as 85% that have been described, PE rates of 20 up to 42% that also have been described. However, much more recent and much larger experiences, especially in the United States and the New York City area hospitals, have shown much lower rates of symptomatic VT events on the order of about 3 to 6 to 7%, suggesting that these earlier reports suffered from reporting bias, especially with the use of systematic screening, and simply overestimation of thrombotic risk relative to the small numbers of patients included in these case series. Nevertheless, even the more recent and more sober implications of thrombotic disease in these patients still represent anywhere from a 3 to 6-fold higher risk of thrombotic complications compared to historical matched controls. And lastly, an elevated rate of arterial thromboembolism approaching 4% has also been described in these patient populations with much less potential for reporting bias. Secondly, the unusual nature of thrombosis in COVID-19 patients is now well described. And on the left-hand side, you see evidence of in situ PE shown by classic filling defects against a background of ground glass appearance in those patients with severe COVID pneumonia. And on the right, one sees evidence of pulmonary microthrombi with fibrin deposition shown in blue stain. As well as evidence of megakaryocytic deposition. But it is this third phenomenon that has many clinical researchers quite worried, this phenomenon of breakthrough thrombosis in COVID-19 coagulopathy despite standard thromboprophylaxis. So that despite standard thromboprophylaxis with heparin or low liquid heparin, especially in ICU settings, confirmed VT event rates as high as 27% have been described. And despite prophylactic and even higher dose anticoagulant therapy, thrombotic complication rates approaching 17% have been described in ARDS patients, which represent a nearly six-fold higher risk of thrombotic complications than non-COVID ARDS patients. And lastly, in at least one small study using systematic screening in ICU patients, despite being on standard prophylactic dose anticoagulant therapy, a VT prevalence of 100% was described in this trial. It is because of this worrisome nature of breakthrough thrombosis that multiple international guidance statements on COVID-19 and thrombosis, including our own from the International Society of Thrombosis and Haemostasis, have advocated for routine prophylaxis with standard dose unfractionated heparin or low liquid heparin, with low liquid heparin preferred in these patient populations due to a more predictable anticoagulant effect. These can be modified to intermediate dose heparin based on a patient's body weight or in critically ill patients, and also consideration for multimodal thromboprophylaxis. And lastly, in patients with high-risk features, consideration for extended thromboprophylaxis for up to 30 days with either a low liquid heparin or direct oral anticoagulant with a DOAC preferred. Now, at Northwell Health, at one point from March to about June 2020, we were the epicenter of the US pandemic, and we saw more patients hospitalized in our 23 hospital system, nearly 13,000 than all of the US hospitals previously. This represented a very large experience, and what we did is very early on, we adapted a very aggressive and universal thromboprophylactic policy using an enoxaparin 40 milligrams daily. For those patients with a BMI greater than 30, we dose increased to 40 milligrams twice daily of an enoxaparin, and also we had a much lower renal clearance than previously used in our system. So we used a creatinine clearance as low as 15 milliliters a minute in these patients, fully expecting an increased heparin exposure in vulnerable populations, and thus the potential to protect these patients from thromboembolic complications. Also, within our Northwell policies, we advocated for post-discharge thromboprophylaxis in patients with high-risk features, such as those with an elevated improved score or those with elevated D-dimers, using a DOAC, including rivaroxaban, 10 milligrams for up to 30 days, or in patients with renal insufficiency, either baby aspirin or apixaban. But it is this pressing question, is exposure to escalated or even treatment dose anticoagulants during index hospitalization, does it have the potential to decrease the coagulopathy that we see in COVID-19, which represents, I think, at this point, one of the most important clinical questions in this population? So we have early evidence that the use of low liquid heparin versus non-heparin users confers a mortality advantage at 28 days, especially in very sick patients with a 40% reduction in mortality. And also smaller studies suggest that the use of therapeutic anticoagulation reduces thrombotic complications in the hospital from anywhere from 40 to up to 70%. And towards this end, there are now over 20 randomized trials of escalated and even treatment dose heparin versus standard of care heparin in hospitalized COVID-19 patients that are being conducted throughout the world. These include the active trials as part of the National Institute of Health, very large trials, as well as the more smaller pragmatic trials, such as the Hep COVID trial that we're conducting within our Northwell system, again, a multi-center trial. All of these study designs are open label. The population is the hospitalized and especially the sick patient with COVID-19. Interventions, again, are comparing intermediate to treatment doses of heparin compared to the controls, which are standard of care heparin. The time of these studies is a fairly short duration, about 30 days, and the primary outcome is either mortality or a combination of mortality, thromboembolic events, and other markers. Indeed, we have some intriguing new data published by a Brazilian group just a few weeks ago, a small trial suggesting advantages of therapeutic over prophylactic anticoagulation for severe COVID-19 patients, again showing improved oxygenation with more ventilator-free days in those patients who were on therapeutic anticoagulant therapy. We also have some brand new data, and this is yet unpublished data, suggesting the value of individualized VTE risk assessment in hospitalized COVID-19 patients. This is using the improved tool plus elevated D-dimers that we were able to risk stratify patients in low, moderate, and high VTE risk categories. And although about 45 to 50% of our patient population was deemed at high risk, there were over 20% of patients that were also low risk, suggesting advantages of or potential for individual thromboprophylactic strategies. The last question is the role of primary thromboprophylaxis, especially in outpatient settings and especially in COVID-19 patients with concurrent cardiovascular or thrombotic risk factors. And towards this end, there are 3 large trials that are placebo-controlled: the OVID trial with an enoxaparin 40 milligrams daily, the NIH trial comparing 2 doses of apixaban 2.5 and 5 milligrams twice daily versus aspirin or placebo, and the industry-sponsored PREVENT HD trial, another large trial comparing rivaroxaban 10 milligrams daily versus placebo. We have the trial design in the bottom of the slide. Again, all of these trials are testing this hypothesis over a fairly short duration and looking at a reduction in either thrombotic events or hospitalization as study outcomes. So, to conclude, we can conceptualize 3 periods of VT risk for COVID-19 patients, and Beverly well summed this up in the previous slide. The outpatient period, which we think represents a low-risk period, but there's some worrisome reports now of an elevated risk of VTE, even in these outpatients, especially with concurrent thrombotic risk factors. And here, the question remains, is there a high-risk subgroup of patients that would benefit from a primary prevention strategy? The hospitalization period indeed represents a high thrombotic risk period, and as was stated, all guidance documents now advocate for a universal thromboprophylactic strategy using standard to intermediate dose aspirin. And the key clinical question is there a subgroup of patients, especially critically ill patients, that would benefit from escalated heparin dose and also multimodal measures? And lastly, in the post-hospital discharge period, we think this represents an intermediate thrombotic risk period, although the data is conflicting. And here the key clinical question is, would there be benefit from a strategy of extended thromboprophylaxis using a DOAC for up to 30 days, again, in high-risk groups? And lastly, future antithrombotic strategies in COVID-19 disease would, again, encompass all of these pre-hospitalization, hospitalization, and post-hospital discharge periods using classic thromboprophylactic strategies with heparin, but the potential, especially in critically ill patients, to use multimodal methods such as fibrinolytic therapy, the use of thrombomodulant, activated protein C, anti-inflammatory agents, and targeted approaches as well. And lastly, the potential to use a dual pathway inhibition strategy using anticoagulants and antiplatelet therapies. Thank you very much.
Well, that was great, Alex. Thank you. You've covered everything there. And I know there's lots of questions coming through for you in a minute. We'll give you a rest and we'll move on to our final presentation. I'm pleased to introduce Dr. Claire McClintock of Auckland, New Zealand. Dr. McClintock is the Clinical Director of Regional Maternity Service for National Women's Health at Auckland City Hospital. She's also a past president of the ISTH. That's very, very recent. Dr. McClintock will be sharing important information about obstetrics and COVID-19. Claire, the stage is yours.
So, good, very early morning to everyone, and thank you so much, Beverly, Barbara, and the crew at World Thrombosis Day for inviting me to come and talk to you about issues relating to pregnancy and SARS-CoV-2 and COVID-19. This is a picture by Egon Schiele, who was a very wonderful artist of the 20th century. And this is a picture of his wife, Edith Schiele. Now, Edith Schiele died in the second wave of the influenza pandemic in the 20th century. She was 6 months pregnant when she died, and her husband, Egon, died also of influenza 3 days later. Fast forward to about 100 years later, and across the world we were presented with influenza H1N1 at the end of in 2009 and 2010. And at the time of that influenza pandemic, we realized that the impacts on pregnant women were really very substantial. And as a study published at the time shows, that of women from almost 30 countries, over 3,000 women, 52.3% of these women were hospitalized. About 1 in 4 women were admitted to ICU, and 8% of the women in this cohort died. And what they showed is that of the 1% of the population of the world who were pregnant at any one time, with that illness, 6.3% of pregnant women made up hospital admissions, almost 6% made up ICU admissions, and almost 6% made up the global deaths from H1N1. And they reported that the risk factors for hospitalization for that illness were actually a low age, ethnic groups in the UK, Black and other ethnic minorities, Hispanic groups in Australia and New Zealand, Maori and Aboriginal and Torres Strait Islanders. Other risk factors were obesity, asthma and smoking. But that was temporized and really outcomes improved with that influenza because of the introduction of the influenza vaccine, and also Tamiflu played a role in slightly modifying the disease outcome. We then were faced, over the years, we've been faced with a couple of coronavirus infections. We had SARS in 2002 and we had MERS in 2012. And those coronavirus had an overall case fatality rate of about 10 to 40%. And studies in pregnancy suggest that the fatality rate for those was about 25%. So in 2019 and in 2020, when we were faced with SARS-CoV-2, there was a concern at the beginning that we might be faced with another disorder where pregnant women might be disproportionately affected. And this is another painting by Egon Schiele called The Dead Mother, painted actually in 2015, some years before the influenza pandemic. And we all know the horrific global statistics of SARS and COVID at the moment. And these we are exceeding these death rates and infection rates every day. So what I'm going to present to you today is just a very basic information about what we know about SARS-CoV-2, COVID-19 and pregnancy. And without going into detail, I just want to say that it definitely appears that women who are pregnant are not more likely to be actually infected with SARS-CoV-2. And also, it really seems that compared to women who are pregnant, if you are a pregnant woman with SARS-CoV-2, you are not more likely to become severely unwell. But the critical factor is that a pregnant woman who is unwell with a respiratory illness can become severely unwell, and especially in the third trimester, where there's the huge amount of blood that needs to go to the placenta to keep the baby viable, then in that situation, a woman with severe pneumonia needs to be cared for extremely carefully because she can become significantly unwell and she may need early delivery. And I'll show some data about this. I'll go over a bit about what the risk factors are for severe illness in women with the virus, and talk a little bit about what the maternal and fetal implications are. I'll go into a little bit of detail about the recommendations about thromboprophylaxis, talk about breastfeeding, and then talk a bit about screening all pregnant women. So a recently published global systematic review looked at over 11,000 women who were either pregnant or were immediately postpartum within the first 6 weeks, who had been admitted to hospital for any reason over 77 countries. And what this study has shown is that about 1 in 10 women at that stage in this cohort were found to be positive with SARS-CoV-2 at the time they were admitted to hospital. Now, interestingly, in that cohort, it seems that there were fewer reported symptoms of myalgia and fever, but there was a slightly higher ICU admission with an odds ratio of 1.62, and these data were more driven by the CDC data from the US. And there are some issues as to whether or not that might be slightly underrepresenting the background numbers of pregnant women. But what this study has shown us is that the maternal mortality in the cohort overall was around about 1%, or 1 in 1,000 pregnant women died as a result of COVID. Now, they've shown in this study what we've seen in, and you've probably heard about all over the world, that the risk factors for severe COVID-19 are age over 35, women who have a high BMI, and that increases the risk by 2.4, women with chronic hypertension, pre-existing diabetes, and were very high risk factors. And a woman who had a pre-existing comorbidity had a 4.5-fold increase in the risk of admission to ICU. Now, in the cohort, the caesarean section rate was up to about 60%. The indications from the study was not absolutely clear to get an idea about because of the way that the studies were presented. But looking at some studies individually, it seems that some of the women would have had an emergency caesarean section because the clinical situation deteriorated such that the baby needed to be born urgently and the woman wasn't well enough for a vaginal birth. The other thing that wasn't shown in this particular study, but has been shown in studies across the world, is that women of Black, Asian and other ethnic minorities are particularly affected, and that is a risk factor in many of the cohorts that have been published individually. But what about the perinatal outcomes? Well, they've shown that all preterm birth has increased threefold, so the rate was 17% overall. Interestingly, spontaneous preterm birth was 6%, so not hugely increased. And it seems most likely that most of the preterm birth was iatrogenic preterm birth and induced because of medical reasons. 1 in 4 of the infants were admitted to the neonatal intensive care unit, but it doesn't actually seem that there's been any increase overall in stillbirth or neonatal deaths. The other thing that they've looked at is what the transmission rate is from mother to infant. And it doesn't seem that there's any direct transmission of the virus in utero from the mother to the infant. And it seems more likely that if the infant is affected, it's more likely to happen in the peri-delivery period in a woman who is highly infectious. Now getting to the nub of the matter for today, World Thrombosis Day, which women need thromboprophylaxis? And I've done of course, we know that today is Virchow's birthday, and in pregnancy, all of the issues that predispose to thrombosis and make up Virchow's triad are affected, with increases in the prothrombotic factors, reductions in a natural anticoagulant, and increases in fibrinogen and breakdown inhibitors. There's increased stasis in the legs and a reduction in the blood flow, more marked in the left than the right. So this will make women more likely to get leg clots, and there's definitely vessel damage. And I don't have time to go into the details of the vessel damage in pregnancy, but all of the things that Lana said about what predisposes to thrombosis outside of pregnancy is equally important in pregnancy. So I put together a synthesis of my recommendations of thromboprophylaxis from data from the RCOG and a paper published by D'Souza and co-workers in the Acta Obstetrica Gynecologica from 2020. So if a pregnant woman is at home with COVID and is self-isolating, it is important that we consider a risk factor if someone contacts us about her. And in this situation, the SARS-CoV-2 or COVID-19 should be seen as a transient risk factor. But if she's well enough to be at home, we should recommend that she keeps hydrated, that she keeps active, and if she's already taking low molecular weight heparin for any reason in pregnancy, then she should continue to take it. If, however, the woman has to go to hospital, critically, we should do another risk assessment when she is admitted to hospital. Again, it's recommended that that having COVID-19 is a transient risk factor in this setting. If she's admitted for a non-COVID reason and the infection is asymptomatic or minor, so say, for example, she pitches up in labour, she's asymptomatic, and she's found on screening to have COVID, to have the virus, but she's otherwise well, then really you need to put this in context with the other risk factors she might have. And she may not need low molecular weight heparin in this setting. However, if she's actually admitted with COVID and she's either got COVID pneumonia or more severe disease, then she should have thromboprophylaxis. Initially a prophylactic dose, possibly dose adjusted, but if she's severely unwell, we might need to consider higher doses, as was outlined in the talk by Alex. Now, in the postpartum period, it's also important while she's still in hospital, do another risk assessment. Things may have changed during the birth. She may have attained other risk factors that would mean thromboprophylaxis in this woman might now be appropriate. And clearly, if she's already has been on thromboprophylaxis, that should be continued. And then if she goes home and has been given thromboprophylaxis in hospital, it's recommended that she complete 10 days of low molecular weight heparin at home. Now, what about a woman who is postpartum, who's at home, and within 6 weeks of birth is admitted to hospital with COVID-19? In this setting, again, she should have a risk assessment done. And if it is thought that she is of high enough risk, she should be given prophylactic dose low molecular weight heparin while an inpatient. And again, this should be continued in the postpartum period. Because it's most likely at this setting, if she's coming in, that she's either coming in with COVID-19, but if she comes in with a non-COVID reason, and again, she's asymptomatic or really not very unwell, she might not need low molecular weight heparin thromboprophylaxis if it's just a finding in a setting like that. Breastfeeding should definitely be encouraged. It's thought that the viral transfer to breast milk is uncertain, but it's unlikely. If a woman has presumed, possible or confirmed infection, she needs to be encouraged and shown how to do careful hand hygiene, and she should wear a mask when breastfeeding or expressing. Now, just a bit about whether or not we should screen all pregnant women, and this is just one of the studies published from New York City. This was pregnant women over 20 weeks who were admitted to 3 different hospitals in the New York Presbyterian area. 675 women were screened for symptoms of COVID and tested for COVID, and 10% of those women were found to be positive. There were over 3/4 of the women, however, were asymptomatic. Some women had symptoms that had resolved, and some women actually developed symptoms later. So what this is showing is that pregnant women in an area where there's, at a time where there's high levels of COVID, have a high risk of having the infection. And I think in these hospitals, in these areas, screening all pregnant women, especially with a rapid test, may be a recommended thing to do. So to summarise again, women who are pregnant are not more likely to be infected, and overall, while they're not more likely to become unwell, if they become unwell with pneumonia, they need very special care, and these women can deteriorate quite rapidly, and everyone needs to be very cognizant of how we manage them. I've gone over the risk factors, which include chronic hypertension, being overweight, being over the age of 35, and women coming from other ethnic minorities, and also women who have pre-existing diabetes. The maternal and fetal implications overall don't appear bad, but certainly a number of the infants do get admitted to the neonatal unit, but interestingly, no increase in risk of stillbirth or neonatal death. I've gone over the recommendations for thromboprophylaxis and emphasised that breastfeeding is safe. And I think that there are definitely situations where we should recommend that all pregnant women are tested on admission to hospital because of the high rates of asymptomatic disease. And finally, I think one of the really important things about COVID that we're learning is it's not just the illness itself that is causing problems for women and for children and for people around the world. The economic hardship of COVID is disproportionately affecting women. Women are losing their jobs. Women who are pregnant are sometimes being forced to have cesarean sections when it is not necessary for this to happen. They are not allowed to be with their birth attendants. Also importantly, violence to women by intimate partners has increased across the world throughout the COVID pandemic. And there is a concern that young girls who are not being able to go to school will have, across the world, will have lifelong interruptions to their education. There are also across the world, there are impediments to children receiving vaccinations, and vaccination programs across the developing world have been affected by COVID-19. So as well as the illness itself, there are many non-infection related causes of the COVID pandemic. And it really behooves us all, when we're looking after pregnant women, to make sure that we don't limit their rights during pregnancy to have a safe pregnancy and provided with safe care for them and their children while they're in hospital and while they're pregnant. Thank you very much.
Thank you very much, Claire. We've run over time. We're just going to extend out a little bit further. We're going to ask you a question, and I'm going to talk about one question that's come up again and again, not just in this webinar, but on many others I've been on. So first, can we ask a poll question specifically about VTE risk assessment? Here we go. If you are a healthcare provider, do patients admitted to your hospital undergo VTE risk assessment? And I'll wait a moment to allow for a response. So are you using VTE risk assessment? Okay, well, whilst we're waiting for the answer, I wanted to ask Alex and Claire, because Lana has had to go to give another webinar at Thrombosis Canada, about how they advise their patients if they have a pre-existing thrombophilia. So they might have factor V Leiden or anti-phospholipid antibodies. They're not on anticoagulation. What should they do when they get COVID, and are they at increased risk of clots? Alex, may I start with you?
Yes, thank you, Beverly. I think that's the important and I would say critical clinical question that is being studied by the 3 large outpatient trials that I've outlined. So the answer is we don't know the answer, which is why we're conducting these placebo-controlled trials. So my first answer is, if these trials exist in your area for your patients, I would strongly urge my patients to enter one of these 3 trials. The OVID trial, I know, is in Europe, and the other 2 trials are being conducted in the United States. If you're not in a region where you do have access to one of these trials, I think, you know, the potential, depending on the nature and extent of your thrombophilia, your bleeding risk factors, other concurrent risk factors, would suggest that either watchful waiting and looking at signs and symptoms of VTE, or if you adopt a more aggressive approach, perhaps baby aspirin monotherapy, 75 to 100 milligrams, is reasonable for a 30-day period. And of course, you should be discussing this with your primary care physician.
Claire?
So I think thrombophilia is one of the other risk factors that's an issue in when you do your VTE risk assessment. I think as a single factor with COVID, it may not be the issue that decides whether or not you get thromboprophylaxis. And I think what we're finding is that a thrombophilia is much more relevant in someone who has a history themselves of a VTE, or someone who might have a family history in a first-degree relative. But unlike as with Alex, we don't know, and we don't have at the moment, we don't have the luxury of having a clinical trial that's going to answer that question. But I think you need to look at it in the context of all the other risk factors that you're faced with.
So I have a slightly different approach, very similar but not quite the same. I want to know when my patients who have thrombophilia get COVID, and I always advise them to keep mobile and well hydrated. Now, if they happen to get severe COVID, and usually most of my patients are young, and female, and healthy, so very unlikely anyway, I really want to know so I can talk to their managing physicians and just check that they're getting adequate thromboprophylaxis. But for me, the prothrombotic state is mainly associated with COVID pneumonia, and standard COVID, where you don't get the pneumonia, the risk appears to be less, especially if you can stay mobile and well hydrated.
I think we do the same then. So, because what you've just said is it's actually the clinical situation that is what determines whether or not you give thromboprophylaxis, which is exactly what I would do. I think the thrombophilia should be seen as one of the other risk factors in the risk assessment, but the driving thing is the severity of the COVID infection that they have.
Okay, I think that's it. Well, I just would like to bring this to an end, to thank the speakers for fantastic talks. And there are a number of questions I know we haven't answered, and we will try and email you some answers to those questions over the next few days. So the recording of the webinars will be available to you if you wish to have a copy. And lastly, we invite you to continue celebrating World Thrombosis Day by joining the World Thrombosis Day Global Twitter chat, taking place in less than an hour at 12 noon US Eastern Time. And please follow the hashtag ClotChat on Twitter to participate and share your thoughts. And for more information on how to get involved in World Thrombosis Day, please look at the website www.worldthrombosisday.org. So thank you very much, everyone, for participating. I hope you have a lovely rest of day, and I look forward to addressing some of the many questions that have been left. Goodbye for now.